I thank the organizers, especially Drs. Liu and Chen, for this invitation to give this talk. I am excited to be part of the conference and disappointed that I won't be with you, but you certainly have expertise there with Drs. Ibrahim and Thompson as invited speakers to answer all your questions. My talk is on inherited liver diseases in children and young adults from diagnosis to treatment. These are my disclosures. I really want to focus this talk on these basic topics. One, some basics of cholestasis. Second, some age-adjusted evaluations of neonatal cholestasis. I'm a pediatric hepatologist, and evolving roles for sequencing and biopsy, and then to talk about some select genetic liver diseases of young adults. First, the basics. As you can see on the left of this slide, this is a graphic representation of the liver and its vascular and biliary connections. As you know, bile acids are made in the liver, secreted into the biliary tree and gallbladder, and after meals travel down the intestines, are reclaimed by the ileobile acid transporter. Dr. Thompson will talk about this in his talk, to go back to the liver. In a variety of liver diseases that we term cholestasis, where there's impaired bile flow, there is liver bile acid accumulation or accretion. And if you are visual learners, this is really what we consider happening, and there are data to support quite high concentrations of intrahepatic bile acids. Well, what happens? Well, we'll start with the liver. Everybody knows this. You have apoptosis and fibrosis, cirrhosis, predispositions to cancer, which I think is quite important, and of course, ongoing inflammation. These are on steroids, quite frankly, in concept, meaning that they increase in amount in the neonate. Even worse in the neonate, because this person wants to grow in the first couple months of life, worse fat absorption because of the lack of bile acids and malnutrition, at times quite severe fat-soluble vitamin deficiencies, particularly D and K, and changes, of course, in the microbiome. But there are also real systemic consequences that even occur in the neonates. First of all, not really neonates, but later on for cholestatic disorders or pruritus, and you can see a picture at the bottom here of a patient with PFIC2. But in the babies, lack of good growth, quite high metabolic rates. There is fatigue, and as we've seen as they get older, altered cognition, ramifications of portal hypertension. And as we and others have pointed out, there are both cardiac and renal pathologies that occur quite early. This is important, not just as patients are adults with chronic liver disease, but also children with cholestatic disorders. So how do we evaluate these? Well, in Europe and in North America, I think this is a pretty decent pie chart of the causes of neonatal cholestasis. On the left-hand side of the slide, I just want you to bin these as extrahepatic, intrahepatic bile ducts, or related to the hepatocytes. And in general, we have about 40% of the time it's biliary atresia. But what I'm going to talk about in this one are the inherited forms or more obvious genetic contributions from the PFICs, the progressive familial intrahepatic cholestasis disorders, and also the idiopathic cases, which are becoming less and less in number over time as we do better with our genetic diagnoses. In a paper led by Dr. Ibrahim, and I'm showing you a highlight here, that cholestasis gene variants have been identified in well over 50 different genes that lead to either disorders on the left for hepatocytes and on the right cholangiocytes. And we really categorize these as either low or high GGT. And these really do help us identify the disorders, but especially with exome sequencing, where we can look at every gene, we're starting to identify new genes and the relevance of identified genes. Even more relevant are those that are on the left-hand side and of this for hepatocytes and the right for cholangiocytes. Those that are bolded and those that I'm highlighting particularly in red that I'll talk about later today, those that are bolded, there are actually FDA-approved therapies, and Dr. Thompson will be highlighting these in his talk. So I want to talk about a diagnostic approach. I want to talk about something new, and I want to also talk about what I think is a point for discussion as we adopt our diagnoses in the current era. Number one, I want to talk about the idea of a quite simple blood test called a direct bilirubin or conjugated bilirubin level. As many of you know, we have found that this is elevated in essentially all biliary atresia patients at birth, helping us change the biliary atresia discussion to one where it's more of a developmental cholangiopathy. But when you have a high direct bilirubin level at birth, it really provides opportunities for universal screening, as well as something to be integrated into the diagnosis. In a nice review paper from Drs. Feldman and Sokol that I give a flow chart on the left, they really start with identifying those patients with a direct bilirubin of 1 mg per deciliter or 17 micromolar. And in North American terms, we do have a good amount of alpha-1 antitrypsin deficiency, but certainly I would encourage citrin deficiency in others, in other parts of the world like yours. And the point here is to take care of things that are important early on, like sepsis, significant things that we can identify on the newborn screen, and certainly obvious surgical issues with an ultrasound. One can also evaluate for addressable issues with infections and pan-hypopit. And in this particular diagnostic, which I'm going to share, I believe I'm going to change in a bit, that there's a primacy of liver biopsy to then tell us whether to do a cholangiogram to evaluate for biliary atresia. I'm going to show you an alternative approach in the next slides. Or afterwards, but I'm going to adjust this on the next couple slides of the order to do genotyping to then tell us what to do. And these abbreviations are just saying whether one does a panel, or one does just exomes, or one does just genomes. These are all local flavor and availability. Bottom line here is we are working to really try to get direct bilirubin into the lexicon for pediatricians and certainly for referring doctors to get these patients to us earlier. And direct bilirubins that are greater than, let's say, 17 micromolar or 20 micromolar or 1 milligram per deciliter really do warrant an evaluation by an expert. But what is that evaluation? And in the current era, it's really this very simple discussion of, on the left-hand side of the slide, do we start with biopsy in the way people like me with gray hair have been trained? We start with the biopsy, or what we're really trying to change the world is, do we really start with doing a genetic evaluation first? And I think that this is certainly, it's the easy answer is, of course, it's personalized, but it really isn't. We really have to think about both at the same time and what's the clinical utility. And as such, I believe the diagnostic algorithms, even those from our last set of guidelines from NASPGHAN, are changing. And for me, I think that what I want to incorporate into this is something that here in Taiwan, you know quite well and have led the world on this, is to look at stool pigment. But I would also say that lab values, as I pointed out on the previous slide, will help. The main issue, I think, is the age of the infant. In addition to that, we're no longer in the past, we're in the future. This is a slide from a New England Journal paper from almost 10 years ago. And basically saying that 10 years ago, the question then was to genotype or phenotype first. I would argue, and if you look on the right-hand side, the timeline here ends in 2015, when genotyping is cheaper than phenotyping. It's also quicker. That one can argue in many situations, genotyping can come first. Again, these are not universal. It's patient specific, and I'll start to try to quantify how to do that. Well, what do we know about things genetically? And I showed you the review paper that Dr. Ibrahim led that talked about all the genes, but we really want to focus on a few genes. And we not only want to focus on just a few genes, we want to focus on one place in the body, and that's the canalicular membrane of the hepatocyte. And the reason for this is that the biliary components are due in largest part by transporter capabilities that reside on the hepatocyte canalicular membrane. In addition to that, when these go awry, and we've known this for over 25 years, Dr. Thompson has led the way for several of these genes, that when these are mutated, we get specific disorders. I want to first talk about what I think is the most, the simplest one in my mind is luckily there's only one bile acid transporter, ABCB11. When this goes awry, all the bile acids that are here represented on the pie chart on the right of what's in bile, again, these are the primary solute in bile, um, don't get into bile and therefore accumulate in the hepatocyte. The other gene that I think is also quite important that I'll spend a lot of time on, especially on the adult side, is ABCB4, also known as MDR3. Not my fault. These genes have more than one name. And also when this is completely mutated and you can't get phospholipids from the membrane or the hepatocyte into bile, you can develop PFIC3, but there are nuances here, as you'll see going forward. Lastly, just for education's sake, direct bilirubin is transported via a different transporter from the bile acid or the phospholipids, and that's this ABCC2. And when that gets mutated, one can get Dubin-Johnson syndrome. But just remember, we focus so much on bilirubin, it's really just a color marker for bile flow. So what about making diagnoses in the modern era? I said we're in the modern era. Well, here's a paper we published a couple of years ago of a gene panel that's readily available here in North America. You'll hear from Dr. Chen and her panel in Taiwan. But this is the panel that we've been using for now almost 10 years. And it's one that included first 57 genes and now 66 genes. It's a pretty wide open way to use the panel. It's funded by several companies. We get the clinical answers. And really the only way we get to use it is we say this is a cholestatic infant or child who does not look like they have biliary atresia or TPN cholestasis. So here's a report we published on the first use of this comprehensive panel of 66 genes, a little over 2,000 cholestatic infants, children, and young adults. But the vast majority, as seen here on the left, were babies. These are the hard ones to diagnosis. More than half of them were less than 6 months of age. What's nice about a panel like this is that the median time to results is about 3 weeks. And I know Dr. Thoreau and other adult colleagues are there from ASLD, and I encourage everybody to really think about this for your undiagnosed patients. So what did we find with the use of a gene panel? 2,000 subjects, targeted panel, do some filtering, and there are 5 designations, all the way from pathogenic down to benign, and including these variants of unknown significance. So what does one find? Well, when we lump these together, we found that there are a total of over 600 variants that were pathogenic or likely pathogenic, including a large number of novel ones, but a huge number, over 3,000 variants of unknown significance from over 400 different variants. This is an expectation. So what about the positive aspects of this panel? 32 genes out of the 66 yielded diagnoses. Of those 32, and only 12% got a diagnosis in this open panel of entry. There were really these 5 that were most prominent. Alagille syndrome was number 1, JAG1 or Notch2. A close second was ABCB11. In our populations, alpha-1 antitrypsin deficiency. But a surprise, and we put this on the panel, was a mitochondriopathy was the number 5. This just tells us that there are some surprises when we do these gene panels. Lastly, I want to mention the variants of unknown significance. This is an expectation. More patients have them than not. In fact, the bigger your panel, the more VOUSs you're going to have. Well, let me give you an example of using this panel where it gave us some straightforward answers. 6-month-old peritic child with organomegaly, direct hyperbilirubinemia, low GGT cholestasis, low serum vitamin D, very high serum bile acid levels. And this patient had when they did the INR, it did not even clot. So we don't even know what the INR was at the time. Genetic analysis revealed homozygosity for ABCB11, the PFIC2 gene. And when you get an answer like this, you don't know what this is other than from the report being pathogenic. And we know what this child has, but what do we do with it? Well, it ends up being, if you look deeply, it's a splice site or chain terminating variant. And as you'll see on the next couple slides, there is a significant risk of hepatocellular carcinoma. This changes the plan, knowing the variant. And when this child was listed for liver transplant early. So take homes from this. The report didn't indicate the variant risk, so there may be times that you have to look yourself. Knowledge changed the care plan, and there's this het here in the cytosterilemia gene, one of them, ABCG5. Just ignore it for now. So I said that there are risks associated with variants, and this is a nice paper from the NAPID Consortium, which is a consortium of PFIC 1 and 2 patients, including the ABCB11 gene here. And these variants were categorized in 3 different ways. 1, mild; 2, 1 mild, not so mild; and 3, just like that patient I showed you before, mutations that lead to a truncated or non-functional protein. So knowing the consequences is important. And here are showing native liver survival on the top in the different BSEP categorizations, 1, 2, or 3, or risk of hepatocellular carcinoma. I want you to focus on this graph and this one. These are the ones with the more severe mutations, meaning that they're going to accumulate bile acids more. Native liver survival drops quite substantially, but this is, I think, quite substantial as the risks of HCC. And so there's a nice flow chart, again, thinking about who should get medical therapies, who should really just go straight to transplant, but definitely who needs more severe monitoring. So more severe mutations, the BSEP3s, like that patient's increased chance of transplant early, increased chance of cancer. So I promised I would get back to the VOUSs. Here's a patient that had neonatal cholestasis. There was no diagnostic, but had 3 different genes, each a heterozygous, each the interpretation is uncertain. And from the reading of the report, we have concluded the variants are less likely to be a primary cause of disease. And I encourage everybody to not take these results and say, aha, I've just made a novel discovery of this triply coincident heterozygosity that therefore gave this kid disease. Don't presume it. Think that these are just like maybe one of the parents. And don't presume yet combinatorial risk. This is the end of 2023. We may think different in 2028 and beyond. And why is that? Well, there is some value that the library is being developed now, and there's a value to reanalyze exome sequencing over time because of we're learning new things. And I'm going to give you a quick example, which I think is quite relevant from the adult world, from Baylor, that has done a lot of exome sequencing of patients, where they looked at patients with neurologic disease. So this is a well-characterized group that they thought had a Mendelian cause, about 250. In 2012, they did exome sequencing and made a diagnosis of almost 25%. They didn't do any more testing of the patients. They just did reanalysis of the exome sequence data from 2012. And in reanalysis in 2017, in a paper that was published in New England Journal in 2019, they nearly doubled the diagnostic rate. And why? Well, variants were reclassified. New information came from the clinicians. New genes were identified. The point being here is an over 20% increase in diagnostic yield with reevaluation, and that this is the point where we're working on ways where we have to reevaluate these sequencing values. Okay, so I promised something new in 2023 for diagnosis of the babies, and I'm going to give you a case. 8-week-old, I'm not sure if the kid had pigmented schools, definitely hepatosplenomegaly, lab values in the biliary atresia range, undetectable vitamin D, but thankfully a nearly normal INR. And what do we do here? And the PTCC stands for percutaneous transhepatic cholangiogram. And we did it in this patient. So when you do this one, you can see that there is a patent intrahepatic and extrahepatic trait. So in that moment in the IR suite, in addition to getting a biopsy, we were able to show that this child is not a biliary atresia. And this didn't come from us. It came from this really nice paper from Toronto, where they did 73 infants. Again, similar to this, median age about 8 weeks, small, about 4 kilos. So for the adults in the room, yes, this is our world. And what were the results in these 73 infants? 40 were normal, like this patient here. 15 were due to TPN, but 33 were abnormal. Those, nearly all of them had BA. They also did simultaneously HIDA scans in 52, of which 41 had no drainage, but 22 of those 41 had a normal PTCC. In other words, it was a coin flip whether the HIDA scan was helpful. Back to the patient. If we just did a liver biopsy, we would have thought this kid had BA, looked like biliary atresia, and in time, the cholestasis gene panel came back without any answers. So take homes here. The biopsy at the same time was quite helpful. BA decisions and surgical decisions can be made instantly. We didn't need an intraoperative cholangiogram. We could relax and wait for potential genetic studies, which of course, in this case, were not helpful, but I would like to consider a final burial for the HIDA scan. So here's my considerations for altering the neonatal evaluation. The toolbox is on the right with lab work, imaging, interventions like PTCC, gene panel, lab work, referrals, etc. But I'd like to think about age at first contact as telling us what we should do and what we should draw from the toolbox. With keeping in mind our target age for diagnosis for biliary atresia is roughly here, from the 5 to 8 week age. So if you get somebody early, like in the first week or two of life, one-time labs and abdominal ultrasound are quite helpful. If they're very sick, strong considerations for rapid exomes or genetics, depending on your expertise. Weekly labs after this point, and thinking about sending the cholestasis gene panel early, knowing that you have time to get the answer. Later on, incorporation of the biopsy and PTCC and potential for the intraoperative cholangiogram. Early on, I guess, overlapping in time, the referrals to surgery and even transplant, depending on the patient. And I'm just incorporating just some very quick pointers on other parts that we use potentially in the workup. So general caveats here are individualize your approach, know your institution strengths, assume about 3 to 4 weeks for results. And stool pigment has value, but I find it not in my hands. The preliminary one at this stage, it's certainly great for screening as you have seen, but it's hard for me. So now for the last 4 or 5 minutes, I want to talk about adult diseases. I want to refer you to this nice paper in JHEP from 2017. All right, just as a reminder, these are the business end of where I'm going to talk about, but I'm going to focus primarily on ABCB11 and ABCB4. Okay, first ABCB4, and this is an old slide because it really is something that's evolving but real. ABCB4 is a real gene in the adult world that I think people need to pay attention to. Wide variety of things that look almost like sclerosing cholangitis, intrahepatic cholestasis of pregnancy, strong diversity of disease. I think it's almost best said in this one paper. Again, this paper is from 15 years ago of one family from Transylvania, fourth cousins once removed, whereas you can see with the arrows and also the clinical information, a wide variety of disorders, including intrahepatic cholestasis of pregnancy, early cholelithiasis, liver deaths. But the index case was a 34-year-old with idiopathic biliary cirrhosis. Wide variety of changes here with this one mutation ahead, by the way, in this patient. Here's a similar example of a patient in 28 years of age. 21 had gallstone pancreatitis, had a distal pancreatectomy and a cholecystectomy, bled 2 years later from varices. Age 27 clearly has end-stage liver disease and had a biopsy, etc., needed to be transplanted. High GGT cholestasis. And this adult, I'm sorry, was a heterozygote. They didn't tell us which one, but was what was known as pathogenic. HETs can mean something. They not only can mean something for disease, it can mean something for cancer, both cholangiocarcinoma and hepatocellular carcinoma. Here's a paper from over 10 years ago. Finally, for this particular gene, and this is two patients that we published, but others have published this as well. ABCB4 variants can mimic Wilson disease if somebody is focused just on how much copper is in the liver. These severe biliary tract disorders can accrete copper. This child had 860 micrograms per gram. And this child was sent to us for Wilson disease that didn't get better with chelation. The reason why it didn't get better with chelation is the patient didn't have Wilson disease. They had ABCB4 deficiency, PFIC3. So please keep this in mind for your own clarity, in addition to small duct PSC. So I'm going to end with the adult genetic variations and give you two examples, one from Denmark and one from Dr. Thompson's group in England. This is a group of 33 patients in Denmark, chronic unexplained liver disease, cholelithiasis, intrahepatic cholestasis of pregnancy, or acute or episodic cholestasis. Looked at these genes, again, ABCB4 and ABCB11, plus a few others. They made a diagnosis in these patients genetically in about half. Quite impressive. This is a really nice paper, again, from Dr. Thompson's group, bigger group, 356 patients, family history of liver disease, chronic unexplained liver disease, as we mentioned. Of these, it's a broader inclusion group. 28% had significant variance in any one of these three canalicular transporters. And so in the interest of time, I'm just going to refer you to the patient, but I want you to see in ABCB4, the number of variants that they found that were monoallelic, not biallelic, was quite high, 65% for ABCB4. In other words, there may be roles for hets in these patients. So the take-home point here is if your patient has one serious mutation in any of these three genes, it may be causative. So to summarize, and a quick tour through the evaluation of the cholestatic infant and young adult. For the infants, age and patient-specific roles for blood tests, imaging, potential for liver biopsy with PTCC and gene panel. And the goal here with the timing, and I really want to emphasize this, we get these kids early, we have time to wait for the gene panel results and stop kids from getting biopsies and IOCs. Note that the guidelines are evolving. There are now pragmatic roles for panels instead of biopsy. Direct bilirubin levels are driving things and act if it's more than 17 micromolar or 1 mg per deciliter. Please note that what we know in December of 2023 for gene variants is still changing. We're creating the atlas. So be wary of overinterpretation of multiple heterozygous reports. And also know for those unexplained, like that patient I showed, that child probably needs an exome, which we didn't do. And if the child did, I would reevaluate it if it were negative. Genotype-phenotype correlations are becoming useful, and some gene variants can predict outcome and indicate therapeutic choices. And finally, which I find most exciting for the adult world and asking the adults to consider gene panels for the right patients, there are probably roles for certain hets in driving disease. And thank you. I hope you have a great, fabulous conference, and I look forward to seeing you at future conferences.